Hello and welcome. We are about to dive deep into a topic that is just so critical in the liver transplant OR, a full 2025 update on ROTEM-Guided Transfusion strategies. We're going to break down the absolute latest in our understanding of coagulation and, more importantly, how you can apply it right there at the bedside.
It is so great to have you with us for this important explainer.
All right, so here's our game plan for today. We're going to start with the real foundational principles of hemostasis and liver disease, and then we'll look at exactly why our old, traditional testing methods just fall flat. From there, we'll get into the nitty-gritty of viscoelastic testing, focusing on ROTEM, and then, the best part, we'll translate all that theory into a practical step-by-step algorithm you can use in the OR. And to finish up, we'll tackle a couple of really critical scenarios and wrap it all up with the key takeaways.
Okay, let's jump right in. For decades, our whole world of coagulation was pretty much dominated by that classic waterfall or cascade model. But here's the thing. In the high-stakes environment of a liver transplant, that model just doesn't cut it anymore. It doesn't capture the whole story. We really need a new way of thinking.
So let's start with the most basic question, right? How does a blood clot actually form inside the body on a real cellular level? The answer, as you'll see, is a much more dynamic and accurate model than those old intrinsic and extrinsic pathways we all had to memorize.
So the modern cell-based model is really a story in 3 parts. First up is initiation. I want you to think of this as just a tiny little spark. An injury happens, it exposes tissue factor, and that kicks off a very small, very localized bit of thrombin production. Now, it's not nearly enough for a full-blown clot, but it's just enough to wake up the platelets. And that brings us to amplification, and this is where things really take off. Those activated platelets, they become the absolute stars of the show. They provide this massive surface area that acts like a turbocharger for the entire process. And then, for the grand finale, we have propagation. This is where the magic happens. A huge thrombin burst right on the platelet surface that takes all that fibrinogen and rapidly converts it into a strong, stable fibrin mesh that locks everything down. Now, we've always known that the liver is the main factory for most of our pro- and anti-coagulant factors. That's day one stuff. But for our patients with end-stage liver disease, or ESLD, that view is, well, it's dangerously incomplete. It's so much more complex than just a simple factory shutdown. And this brings us to what is maybe the most crucial concept we'll talk about today: rebalanced hemostasis. Think of it like a new and very, very fragile equilibrium. In ESLD, the liver's production of both the things that promote clotting and the things that prevent clotting goes down. But at the same time, other compensatory mechanisms kick in. And what you're left with is a system that's balanced on a razor's edge, ready to tip over into either massive bleeding or catastrophic clotting at any moment. Okay, this table right here, this is where it gets really fascinating, because it lays out the central paradox that we're dealing with. So yeah, on one hand, pro-coagulants are down. Of course, that's why the INR is high, that's why these patients bleed. But look at the other side of the equation. The body's own natural anticoagulants, things like protein C and S, they're also down. And then you have these incredible compensatory changes. The endothelium starts pumping out more Factor VIII and von Willebrand factor. And to top it all off, the enzyme that normally keeps VWF in check, ADAMS 13, is also deficient. So what's the result? You get a system that is flooded with this hyperactive VWF, which just promotes more and more platelet adhesion. It's this incredibly complex push-pull system that's in a really, really precarious balance. And this quote from Belesnover and his colleagues, it just sums it up perfectly. We are managing patients who are, at the very same time, at risk for catastrophic bleeding and life-threatening clots. That duality, that paradox, is the central challenge of managing coagulation during a liver transplant. All right, so let's move on. If the system is this complex, this rebalanced, how could a simple lab test possibly give us the whole picture? Well, the short answer is it can't. And that's how this new paradigm completely undermines our old reliance on traditional lab tests. This question really gets to the absolute heart of the problem. We have studies that have shown that even with a sky-high INR, the overall ability of these patients to generate thrombin can be totally normal, or sometimes even elevated. So what does that huge discrepancy tell us? It tells us the INR isn't measuring what we think it's measuring in this specific group of patients. It's completely missing the bigger picture. And this slide gives us the absolute perfect analogy to understand the difference. Think about our standard lab tests, the SLTs, like PT/INR, as a single static snapshot.
They measure one isolated event, the time it takes for the very first strand of fibrin to form in plasma that's had all its platelets stripped out. But viscoelastic tests, or VET, that's the whole motion picture. You use whole blood, and you get to see the entire story unfold, how the clot gets started, how it builds strength with help from platelets and fibrinogen, and then, if and how fast, it starts to break down. The bottom line is simple. SLTs give you one frame, while VET shows you the whole movie. So now that we've established we need a better tool, we can turn our focus to viscoelastic testing. We're going to get specific now and really concentrate on ROTEM, which stands for rotational thromboelastometry, and figure out how to master its interpretation. So ROTEM and TEG, they're the two big players. And fundamentally, they do the same job, but they get there in slightly different ways. The original TEG works by spinning the cup around a pin that stays still. ROTM flips that idea on its head. The cup is stationary and a pin rotates inside it. Now that might sound like a tiny detail, but it actually makes ROTM much more resistant to all the bumps and vibrations of a busy operating room. But here's the real game changer. ROTM uses specific targeted reagents in its different channels. This allows us to surgically dissect the coagulation process, to isolate different components and to pinpoint exactly what's going wrong. And that is the key to targeted therapy. Now, within the ROTEM family, you're mainly going to see two devices. The ROTEM Delta is the workhorse that many of us grew up with. It's a fantastic 4-channel semi-automated system, but it does require you to manually pipette the blood samples and reagents. The newer ROTEM Sigma is fully automated. It uses this brilliant all-in-one cartridge system, so there's no pipetting needed, which really cuts down on the potential for human error. The really important thing, though, is that they both use the exact same core technology. So all the algorithms and treatment thresholds that were developed on the Delta can be used directly on the Sigma. Okay, this slide, this is the absolute heart of ROTEM interpretation. Each one of these assays gives us a unique piece of the puzzle. So XTIM is our quick overall look at clot formation activated through the extrinsic pathway, kind of like a PT. INTIM looks at the intrinsic pathway, like an APT. But the real power of the system comes from the other assays. FibTIM, honestly, this is probably one of the most powerful tools we have. It uses a reagent that completely blocks platelet function, so we get a pure, unfiltered view of exactly what fibrinogen is contributing to the clot. This is absolutely critical for knowing when to give cryoprecipitate or fibrinogen concentrate. Then you have APTIM, which has an anti-fibrinolytic in it. If your APTIM trace looks great but your XTIM trace is falling apart, you have just definitively diagnosed hyperfibrinolysis. It's that simple. And finally, HepTIM has heparinase in it, so you can quickly figure out if a long INTIM is just due to heparin. All right, let's get to the most practical part of our entire discussion. We've gone through the theory, we've looked at the technology. Now, how do we actually use this information to make real-time, life-saving decisions in the operating room? Let's turn this theory into practice. You know, effective management isn't just about doing one test. It requires constant vigilance. This timeline shows us the key checkpoints. We're not just grabbing samples randomly. We are specifically targeting the moments of highest physiological stress. I'm talking about the hepatic phase, and especially right after reperfusion. That's when the coagulation storm really hits. Frequent sampling lets us navigate that storm proactively instead of just reacting to the chaos after it's already started. Now, before we even glance at the ROTEM screen, we have to address the fundamentals. This is so important. The entire coagulation cascade is just a series of enzymatic reactions, and those enzymes are incredibly sensitive to their environment. So here's a huge takeaway. You must correct the underlying physiology first. Throwing factors and blood products at a patient who is cold, acidotic, and hypocalcemic is like trying to light a fire with soaking wet wood. It's just not going to work. It's ineffective and it's wasteful. You have to warm the patient, correct the acidosis, give calcium, and make sure they have enough oxygen carrying capacity. This table, this is our clinical playbook. It's a clear step-by-step guide that takes you from the problem straight to the solution. So if you see a long XTIM clotting time, what's the problem? Well, the engine won't start. It's a factor deficiency. The solution, FFP or PCC. What if the 5-TEM amplitude at 10 minutes is low? The problem isn't the engine, it's the bricks and mortar of the clot. You don't have enough fibrinogen. The solution, cryoprecipitate. And what if the overall XTEM amplitude is low, but your 5-TEM is totally fine? Well, the bricks are okay, but you're missing the construction workers. It's a platelet problem. The solution is to transfuse platelets. It's just a beautifully logical system. And one more time, just a quick but very important reminder. These are example thresholds. Your own hospital's specific protocol should always be your ultimate guide. Now, let's take a look at two critical and completely opposite conditions that can pop up during a liver transplant. We're going to see how ROTEM gives us a unique and absolutely essential tool for identifying and managing them quickly. We're talking about hyperfibrinolysis and hypercoagulation. Okay, first up, let's tackle hyperfibrinolysis. This is a state where the clot is breaking down way too fast. We often see it right after reperfusion of the new liver, thanks to a massive release of tissue plasminogen activator from the donor graft's endothelium.
The classic ROTEM signature for hyperfibrinolysis is something you'll never forget once you see it. The trace starts to build a nice, healthy clot, but then it just melts away. It narrows into this characteristic spindle shape right before your eyes as the clot dissolves. And this is where the diagnostic power of that AP-TEM assay is just brilliant. When you run it at the same time, the anti-fibrinolytic that's in the reagent prevents this breakdown, and you get a normal, stable curve. That dramatic difference, the collapsing EX-TEM right next to the healthy AP-TEM, that is your definitive diagnosis.
And once you've confirmed it, the treatment is very straightforward. You give an anti-fibrinolytic agent like tranexamic acid. The critical takeaway here, though, is that this is a targeted therapy. We treat what we see on the screen. Giving these drugs prophylactically, just in case, is dangerous. If that patient is actually tipping into a hypercoagulable state, you could be throwing gasoline on a fire and triggering a massive, life-threatening clot.
Okay, so now let's flip the coin and talk about the opposite and equally dangerous condition, hypercoagulation. This is a state of excessive, super fast clot formation that puts the patient at an extremely high risk for things like portal vein thrombosis, hepatic artery thrombosis, or even a clot forming right in the heart.
The ROTEM pattern for hypercoagulation is the exact mirror image of what you'd see in a bleeding patient. The clotting time, or CT, will be really short. The amplitude, which we see in the A10 and the maximum clot firmness, or MCF, will be really high, creating this wide, beefy-looking trace. This is telling you loud and clear that the blood is forming a very strong clot very, very quickly, and that means a significant risk for thrombosis. So managing this state is really all about avoidance and vigilance. The very first and most important thing you do is stop giving pro-coagulant factors. Do not give FFP or PCC to a patient whose ROTEM is screaming hypercoagulation. And of course, immediately stop any anti-fibrinolytics. This is also where your TEE becomes an invaluable tool for spotting an intracardiac thrombus early. Maintaining good hemodynamics and flow is key, and in really severe cases, you might even consider therapeutic anticoagulation with heparin. Okay, we have covered a huge amount of ground today, so let's take a minute and distill all of this information down into a quick reference guide and then summarize the most important takeaways from this whole explainer. I want you to think of this as your cognitive aid for the OR. A long XTEM CT triggers factor replacement. A low FibTEM MCF triggers fibrinogen. A low XTEM MCF when your FibTEM is normal points you to a platelet problem. And significant lysis on the XTEM trace triggers antifibrinolytics. It's a simple if-then guide. And just one last time, these are example thresholds. Your own hospital's validated protocol should always, always be your ultimate guide. So, to wrap it all up, here are our 4 key learning points. First, please remember the concept of rebalanced hemostasis. These patients are not just anticoagulated, they live on a razor's edge between bleeding and clotting. Second, traditional labs like the INR are not just unhelpful, they can be actively misleading in this patient population. BET is the superior tool, period. Third, ROTEM lets us practice truly goal-directed therapy. You're not just throwing blood products at the patient anymore. You are precisely correcting the specific deficit you've identified. And finally, the ultimate benefit of all of this is better patient care. Fewer transfusions, fewer complications, and better outcomes. And as we finish, I just want to leave you with one final thought, a forward-looking question. We've made these incredible leaps forward with VET, moving from these blind transfusion protocols to truly goal-directed therapy. But what? What comes next? As our technology and our understanding of this unbelievably complex physiology continue to evolve, what do you think will be the next frontier in creating a truly personalized coagulation management plan for every single patient who comes for a liver transplant? Thank you so much for joining me for this explainer.